So I'm Manali, I'm a GP by background, and I'm one of the associates for the Nottinghamshire Alliance Training Hub who have brought you today's session. We will be discussing care coordinators and how we can work more in an integrated manner alongside our colleagues. So working alongside care navigators, social prescribers, but also our health and wellbeing coaches. We've got a fantastic team who are presenting for you today. We have Darcie Parry, Gracie and Joshua, and without further ado, I'll hand over to the team. Thank you.
Okay, so hello everybody. I'm Darcie Parry. So a lot of you I think already know me, but I'm the Care Coordination Ambassador for the NATH team. I'm also a Senior Care Coordinator as my day job in a single practice PCN. So just a couple of bits of housekeeping really, just the usual. Feel free to use the chat bot or raise your hands for any questions. If you do have a question relating to a certain topic, you're fine to ask it, but any general questions we do ask that they wait until the end, because we'll have kind of like a little Q&A session if there are anything anyone wants to bring up. Wonderful, there we go. Yeah, so I'm the Care Coordinator Ambassador for Nottinghamshire Ambassador. So I kind of work on promoting the care coordinator role itself and enhancing it, looking into like workforce development plans, and trying to kind of develop them and make sense of them in a way to try and make sure that everybody's doing the same job. I look at things like education for care coordinators, so opportunities for people to enhance the skills, looking at courses that they can do or looking at career progression. And then alongside just doing general peer support, we have a peer support network that works quite successfully, just with basic peer support for everybody that does the job really. So this is just a little bit more on the role. So basically, I also work with different stakeholders and see how we can develop as a role across the board and look at the understanding of the role and how it fits into primary care, which is the main reason why we are doing this presentation today. There seems to be an ongoing misunderstanding of the role, particularly around care coordination and care navigation, which is why Grace is here to speak about care navigation today. And then there also seems to be some kind of miscommunication and misunderstanding of the roles between care coordination, social prescribing and health and wellbeing coaching. All three different roles, but all work very closely together normally to try and, you know, work in a person's best interest and get them the best care that they can throughout primary care. So I'm going to start off just by talking a bit about what a care coordinator is, what we do. Please do bear in mind that when I'm talking about specific areas, it may not relate to you, but we all do try to work in a similar way. But care coordinators can have a vast level of knowledge. Everyone tends to work in different areas throughout, which I will explain on the next few slides. So a care coordinator does work under ours, so we are under the Additional Roles Reimbursement Scheme, and we are there to support patients in a person-centred way and make their care easier to understand and maintain. Again, we can work through a load of different kind of cohorts of patients. Myself, I work with severe mental illness, multiple disadvantages, learning disabilities and care homes, whereas there is a massive list of things that we can do. So we do tend to base ourselves around a certain cohort. So you can have cancer care coordinators, you can have people that are based on long-term conditions, you can have people that are based, again, like myself, on learning disabilities. It's an endless list realistically, but as long as you can find an avenue to actually coordinate that care and take that person's care in a way under your own hat, so that you are supporting that patient throughout everything, helping them to manage appointments, doing appropriate care plans and such. So yeah, like I said, we do all tend to have a caseload of patients who we support, and these can be ranging from a list of, you know, it could be 2,000 patients. If it's a long-term condition list, they tend to have obviously a lot more patients that are under those, because there are quite a few long-term conditions where we can kind of just monitor people for being invited to reviews, making sure that follow-ups are done, or we can be a lot more involved in people's care, such as care homes, where you can do individual care plans for every single person. It just completely depends on the caseload that you have as to how you kind of manage that. So the things that we can look at, again, arranging condition reviews, we can look at combining appointments. So when we get to know a person and their needs, we can look at combining, this patient needs bloods, this patient needs a review, let's get them in together, so that they're only having to kind of tell the story as minimal times as possible, so that they are kind of not having to access the surgery as much as it would be if everything was separate. So kind of looking at a person-centered way to get everything done in one. So again, creating about me and personalised care and support plans. These only come into play for certain cohorts who need them, particularly with care homes, normally with learning disabilities, some mental health, those sort of things. But they are a great way of getting a person really involved in their own care. So it helps them express their needs, express how they want to kind of be cared for. You know, you can get a view of people's communication difficulties, you can get a view of people's kind of like accessibility needs, anything along those lines. So they are a great way to support people if they are applicable to the role that you do. But yeah, so other areas that care coordinators can support with, there's mass invites. If you've got a very large cohort, they can go out to kind of like support an entire cohort of patients at once that are due for certain reviews. Some of the care coordinators in the area do tend to carry out actual reviews, particularly cancer care. I know that a lot of cancer care coordinators do kind of actually get really involved and do some of the cancer care reviews. So they're things that we can help with. Learning disabilities and mental illness, we can touch on that to support the GPs and other healthcare professionals by doing plans or whatever needs we can do. If you do have a manageable cohort, you know, we can act as a point of contact for certain cohorts to discuss and personalise their care within primary care. So we can obviously support them. If they ring up and they are due for a blood test and struggling to get through to reception or anything, it's something we can help arrange. We can look at all sorts of avenues for them. We support with kind of like childhood vaccinations, baby checks and postnatal care. If we are obviously under that hat, that's something that they can support with. We can support with obviously vaccination clinics such as COVID and flu, if that's under our remit. We've come across a few that are kind of like vaccination led care coordinators, so that more comes under their hat, but that's something that we can obviously have a look at supporting. And we can look at referring on for certain kind of like cases that we do have onto services like weight management, so smoking cessation, talking therapies, etc. But that's kind of like where we link in with social prescribing, which we will talk about later, because there is a difference between the level of referring that care coordinators do and social prescribers. So again, that'll be picked up later on. Okay, so the pathway to becoming a care coordinator, there isn't any specific educational requirements to become a care coordinator. There are a few following attributes that we do look for. So obviously people that have worked in health and social care or other support roles that are in direct contact with service users, families and carers. We look for people who have worked in MDT environments beforehand, if again that is applicable to the role that they will be doing. We look for people who work with cohorts of people where best practice is supported, again, like the vulnerable people or the elderly, and experience in support planning. But this isn't a definite, this is just something that would be role specific, dependent on what they're actually going to be doing as a role. So whatever the cohort is, that's what it would be based on, but there's no actual requirements to become a care coordinator. So looking at the skills and the understanding that is required, I do like people to, you know, have a basic understanding of regulations around health and social care, personalised care, the importance of EDI. They do like to look at obviously organisational skills, diary management, etc. And if applicable again to the role, there's having the understanding of safeguarding children and vulnerable adults, and obviously meeting DBS reference standards and criminal record checks. So mandatory training for care coordinators. So this is something that we've tried to have a big push on for the past probably year and a half. There is actually mandatory training, which not everybody seems to know about, but this is another thing to do with the misunderstanding of the roles. So all three roles, care coordination, social prescribing and health and wellbeing, do have mandatory training. So there is the 2-day PCI accredited care coordinator course, which is mandatory for all care coordinators to be doing the job. There's the PCSP training and the shared decision making training, which they're just both e-learning modules that can be done normally through the Personalised Care Institute. But there is definitely mandatory training for it. So if anybody needs any more information on this, please feel free to message me after this meeting. I'm happy to assist with obviously people getting access to this, but it is funded through your own PCN, just so that everybody is aware of that. Okay, so care coordination and care navigation. So this is where Gracie comes into play. Hello. So I'll just go through the care coordinator bit. Gracie, if you then want to speak about care navigation, would that be all right?
Yeah, perfect, no problem.
Wonderful. So there is a difference between care coordinators and care navigators. This is something, since care navigators were named, obviously care navigators are really the receptionists and admin team that work within a primary care network, whereas care coordinators do technically an admin-based role, touching on clinical, but we are rather different roles that do work together. So care coordinators, like I've said previously, we deal with our own cohort of patients. So we will be based around normally one or two particular sorts of cohorts. So again, mental illness, cancer care, long-term conditions. We support ongoing care planning, arranging reviews and support. So we are quite, in a way, limited to who we do support as an individual. We try to work with specific patients to support the needs and make necessary referrals. So we actually do outward referrals. So like I said beforehand, weight management, smoking support and mental health support. But we do those for our cohorts, whereas normally a care navigator would, if they've got a care coordinator appointed to a certain type of care, they would normally send the referral over to us to complete for them. So we're the ones that would make those referrals for the patients. And then we kind of have more time to get to know certain individuals that are on our caseload, particularly, as I say, if you do deal with a smaller cohort of patients. So we have the opportunity to create tailored and person-centred approaches, again, like care planning or just knowing people's communication needs, knowing how best contact preferences, stuff like that. So we work with the patient to try and make the care as person-centred, as personalised as possible for them. But that's just having a much smaller cohort of patients as opposed to care navigators. And care coordinators are trained thoroughly in person-centred support planning, shared decision-making and cohort-specific training if required, such as mental health or cancer, whatever specific training you do, we tend to have been trained for that particular role. So, Gracie, if you want to speak a bit about care navigators.
Hi, so my name's Gracie. I'm a care navigator in reception. So it's a new role within our reception. So there's me and my other colleague that do it. So we basically work with all patients, so the whole number of the practice, and we deal with them firsthand. So we navigate whether they need healthcare or social care, basically, and it helps within difficult situations where to signpost them to, and to have the connections with the care coordinator team, so you can touch base as and when. Care coordinators do have more of a rapport with the patient because, like Darcie says, they've got more of a cohort of selected patients, so it's easier to check up on them as and when. On reception, it is quite difficult, as you can imagine, to be doing things like that, but as long as we've signposted them in the right direction, then we know that their needs are met. So we just, do appointment bookings, ordering medication, clinical requests, messaging GPs, anything like that. If a patient does have like, for example, a learning disability, it will say that, so we then know on reception just to give them more time and support when dealing with them when they do call or require anything like that. So me and my other colleague have actually had training in dealing with difficult situations within reception, and I think that's helped within our role, because as you first get a call on the phone, and it is in regards to a social or a healthcare setting, they can be quite difficult as first hand to know where to signpost them to. At the first stage, the patient or whoever is calling in regards to the patient could maybe be a bit stressed or worried or anything like that, and it's our job to then calm them and navigate them to the right to the right department, basically. So yeah, we book all appointments with healthcare, so your health checks and everything that the care coordinator team do, we make sure they're booked in with the relevant appointments. Your diabetic checks, your asthma checks, anything like that, baby vaccines, anything like that, they'll leave a note, and that makes it easier for us on reception to get them booked in, then that's done, kind of thing. So yeah, basically that is the head and tail of a care coordinator, a care navigator, sorry.
Thank you, Gracie. Yeah, so there's a lot of very similar ways of working between care coordination and care navigation, and they do work quite closely together. It's just kind of like that patient-specific cohort that care coordinators have, whereas care navigators are kind of your first point of contact for normally primary care. So they will be the ones that pick up the phone and support patients with their requests, which is obviously sometimes requests for care coordinators. So they work side and side. Yeah, so it is just a bit more on just how we work together. So we communicate patients' needs and preferences to be able to enable more personalised care. This especially comes into terms of patients that are kind of like your learning disability patients and things like that, because if they do have accessibility needs or they do have communication needs or anything like that, this is something that care coordinators can assess and then add to patients' records for care navigators to be aware of and to take into consideration. So it's providing more person-centred care throughout both avenues. Like Gracie said, we work around booking appointments and reviews, supporting each other. Both act as first point of contact. So say someone's trying to contact me, I'm not there, they can contact obviously care navigators, and they can support as best they can, or get support from the care coordination team, or just advise somebody that, you know, if it's me specifically they're wanting to speak to, or any care coordinator, that we'll get back to them as soon as we can. Yeah, and I think the last one, realistically, Gracie explained perfectly, just about the whole support planning and everybody explaining processes and stuff to patients. Yep, so yes, that's really what wraps up the differences and the integrated ways of working between care coordination and care navigating, just how they work alongside each other, really. So the next part we're wanting to look at is the differences between care coordination, social prescribing and health and wellbeing coaching. So that's where Joshua comes in.
Thank you. Hello, everyone. So my name is Josh Emery. I am the social prescriber, link worker manager and health and wellbeing coach lead, and in desperate need of a more succinct job title, for sure. It's immensely long, probably reflective of the wide ranging teams that I look after. So I look after the social prescribers at PICS, mainly in and around mid-knots, but in any as well, and across a variety of different PCNs. And then I also look after the slightly smaller team, but albeit sort of growing team of the health and wellbeing coaches. I'm going to start by just taking you through a sort of brief overview of each role, and then I'll try to differentiate between some of the differences between what's expected and how you can sort of get in touch and refer through all of them. You want to flick us on, Darcie, to the next slide, please. So you've heard a really good and thorough overview of the roles there. I'm going to try and do my best to explain to you the social prescribers, the health and wellbeing coaches. I'm going to start with health and wellbeing coaches because there is slightly more straightforward than the social prescribers. So our health and wellbeing coaches perform a variety of roles, and critically they support patients around their physical and also their mental health needs. And one of the emerging roles certainly in the last 18 months or so is a bespoke role which we call a mental health and wellbeing coach. I currently have 4 of those who sit within my team who directly offer first line support for patients with their mental well-being, and that is around low to moderate mental health concerns, anxiety, depression, low mood, etc. The physical health coaches cover the physical element of health, which, as you can imagine, is immensely varied. They work with patients who are diabetic, COPD, high blood pressure, loads of different cardiac pathways. They do falls prevention, essentially, my tagline for health and wellbeing coaches is that any modifiable disease factor that might be made better through some sort of physical activity or some sort of dietary intervention, that's where our health and wellbeing coaches can come into play in relation to any disease factors, really. The support that they provide is an intervention which is based on the behaviour change model, and all of the coaches work on a setup, if you like, with their patients that they're absolutely not there to tell, but they're there to coach. This is not a sit-down education session where the patients will be, littered with 12 different weeks of don't eat this, do eat that, don't eat this, do eat that. It is a behaviour change model. It is all about working with the patient to determine what's going to work for them and how we're going to get the best outcomes together. And that holistic approach has been really, really beneficial. I've got some statistics and some case studies that I think we're going to share with you all later on after the presentation is finished. But you'll see some really amazing first-hand feedback from our patients. The way in which the health and wellbeing coach is set up can be delivered across a variety of interventions. So they deliver one-to-one clinics, that might be face-to-face, you might have seen some of them knocking around in your practices. They deliver telephone clinics, and they deliver online support, all on a one-to-one basis. And they also deliver a variety of different group interventions. Those group interventions, again, vary from PCN to PCN, and I won't go through every single group option that's available, but we do group-based exercise classes in local leisure centres. We do group-based diabetes education sessions. We do a group-based falls prevention class. We've just launched a group-based aqua falls prevention class. There is a plethora of things that are available through your health and wellbeing coach. The overall kind of goal and ambition, if you like, with the patient is to provide around about a 12-week intervention, and there is a little bit of flex around that, but in the main it's around about 12 weeks. And what we're looking to do is offer anywhere between sort of 6 to 8 sessions within that time. Usually start on a weekly basis, and then they move through to a fortnightly basis. We'll set the patient some goals and ambitions. That might be weight management, it might be a reduction in their blood pressure, it might be a reduction in their HbA1c, and then we'll work with them to support them through that. The critical thing with the health and wellbeing coaching is that whilst it's not a clinical role, it very much focuses on clinical markers and clinical outcomes, with the role and ambition then of providing an onwards referral pathway and a network for that patient to continue away from the health and wellbeing coach. A good example of that will be our exercise classes. So we might invite the patient in for a 12-week exercise program with us. This person might have come from doing very little to no physical activity. We introduce them back into the gym, we prepare them for physical movement, and then critically we link them in with perhaps one of our leisure partners who would then talk to them about a gym membership, an exercise referral scheme, for example, and they are moved away from our caseloads. So the health and wellbeing coaches work very much on a clinical outcome basis. We're KPI'd on things like weight management, on things like improvements in mental health, etc., etc. So that's a nutshell, if you like, overview of the health and wellbeing coaches. We move on to the social prescribers. Now, the social prescribers do a lot, I think it's fair to say. It's very, very difficult to put their role into very, very specific wording, because in general, they pick up so many different projects and so many different patients. The aim of the role, as you can see there, is to provide a non-clinical, non-medical service which looks at community-based support and community-based assets to allow the patient to access things, support, networks, avenues that they may have not been able to without the presence of our social prescribers supporting them. That's the original model. In reality, our social prescribing team are involved in just about anything you can think of. They're in housing, they're in debt management, they're in mental health, they're absolutely everywhere. And again, each PCN has a very varied and different approach to what each social prescribing team looks like. The aim and ambition, again, is to try and get patients in for around about a 12-week period, although we know that that's certainly not as clear within social prescribing because of some of the delays on onward services. I guess the critical difference between the health and wellbeing coach and the social prescriber is that while the health and wellbeing coaches are focused on very much the doing, if you like, they are going to provide the bespoke advice on managing your diet, or they are going to provide the bespoke advice on improving your mental health and wellbeing. Our social prescribers will very much play a role in linking the patient up with the local services that are available. So they wouldn't necessarily provide direct support and avenues on diet, but they would, for example, refer back into our health and wellbeing coaches or onto the county weight management service, or perhaps they would link the patient with the necessary contact details for Slimming World, for example. Inside the social prescribing setup, if you like, are a range of KPIs that are much looser set in terms of what the outcomes are looking for. Effectively, the main reason and the main purpose for social prescribing, like many of the R's roles, is to take pressure away from GP practices, and as a result we don't provide them with direct you must see this number of patients, or you must see this outcome from your patients. Essentially, if our social prescribers can evidence that they are doing work that removes the stress and demand from GP practices, we're happy with that work, and the outcomes are phenomenal. Again, I can share with you some case studies that come through there. I've touched upon the varied nature of social prescribing, and there are just a handful of different options that are available there in terms of patients who can come through. So again, mental health, long-term conditions, social isolation, complex needs, the list really goes on and on and on as to who social prescribers can see. I would highly recommend a look through either F12 or some of the referral information, and that will show you your PCN specific information on what each social prescribing team can provide for you, depending on what area that you're in. I think, Darcie, that's as neat an overview I can provide without boring everybody to death. You're on mute, my love. My apologies.
Sorry, I am on mute. You're right. Thank you for that. That was wonderful. So there's obviously we've already gone through the overview of health and wellbeing and social prescribing. So looking at the care coordinators, so all of this information was pulled from the workforce development programs. Obviously, Josh has expanded on it brilliantly. But it this is set out to show the actual differences in how we all work. So the care coordinators are the ones that are based more within primary care and secondary care services, but we kind of deal with the cohorts as previously discussed. I'm not going to go through everything again as I have previously, but we would patients in our cohort, so say mental health patients, if they were struggling and they had any needs for any support with housing, any needs to do with drugs or alcohol related support, or they just wanted somebody to talk to, that's where we would refer to the social prescribers or the health and wellbeing coaches, dependent on the needs of the actual individual. So we would obviously help them navigate their care throughout primary and secondary care services, but also onwards to social prescribing for things that are kind of like community based, which is anything that can support them with whatever the needs are realistically outside of primary and secondary care. I don't think I really need to go through this overview much, because we've already covered a lot of what a care coordinator does. We just kind of like enable effective care flow and needs monitoring and support where we can, but a lot of the social prescribing health and wellbeing coaching we will actively refer on to. But yes, so let me go on to the next slide. So we've got this again, the care coordinator workforce development summary. So this is again just pulled from the workforce development. It's just an overview of everything that I've already said to do with care coordinators and what we do. So this will be handed out at the end. We are going to do some handouts that will be sent to everybody via email that you can read through, but this is just basically expanding on everything that we've already discussed, again with the minimum training requirements as well that everybody would need to access if you are a care coordinator or you do any of the other roles. So the social prescribing link workforce development summary, again Josh has gone through a lot of this already. It's just expanded from the last page that will be a handout, but there is also mandatory training included for the social prescribing, which is 12 modules. I believe that they are all current and they are correct, aren't they, Josh? Those
Yeah.
So yeah, it's all 12 of those. So again, social prescribing does have mandatory training that does need to be doing for people that are in the role. And then we go on to health and wellbeing. Again, with health and wellbeing coaching, the mandatory training is a 4-day Personalised Care Institute health coaching training that everybody should be doing. I am aware that dependent on how your role works, now you do integrate with social prescribing, care coordinating, or health and wellbeing coach as opposed to one of those roles that you do. I know that some roles do end up doing all, 2 or 3 of the actual mandatory training for other roles just to try and kind of like integrate. I know some care coordinators have actually done the social prescribing training or the health coach training just so that they can like work in between all 3 roles if that's what their role needs, but that's very few and far between that people do that. But some people do tend to work that way, where they do a combination of the roles, but it's not actually a role in itself, it's just kind of self-development, if we can say. So the integrated working between care coordination, social prescribing, and health and wellbeing coaching. So we work together through mutual patients, so communicating quite effectively for combined medical, social and wellbeing support. So this is the basis of how we all work together. So obviously if somebody's in primary care, they're receiving medical support from a care coordinator. For example, it could be mental health. So they're due for a mental health review. We contact them, book them in for their appointments, can do follow-ups with them, act as a point of contact. But if they're voicing that they need help with their finances and their housing and that sort of stuff, we can then refer on to social prescribing, who can help them with all that, and then obviously the wellbeing support for anything further that they may need. So we work together in that kind of aspect, sharing mutual patients. And the signposting, that also rolls into that. So obviously signposting from one role to another, whereas somebody may come into social prescribing for an issue to do with finances and housing, but then the social prescriber might identify actually they need some kind of care coordination through their medical support as well within primary care. So it works both ways, signposting to and from each role. Information sharing, so looking at having a more tailored approach. This would be through things kind of entries on system 1, but also through care planning and kind of like reasonable adjustments and those sort of things. So if one of us is filling it in, the correct forms or the correct questionnaires and stuff with patients, we can all access it, and it just helps everything tied together. It helps everyone share that information that's kind of person-centered and necessary to the patient to make their care more navigatable and accessible for them. So another thing that we do find, particularly within our PCN, is the increased contact opportunity. So obviously if someone is actively being seen by a social prescriber but they don't necessarily engage with primary care, it can be kind of like they could be picked up with a social prescriber, and we could use that contact to try and say, you're due for your mental health review or your learning disability review or whatever. Is this something you look at? Is it something you're interested in having done? And kind of talk each other through to try and get people to access each other's services. So try and, use the roles to get information out to people that needs to obviously be passed over to them, particularly for hard to reach patients. I mean, we all have them, we all know how it goes, but it just creates them extra contact attempts. And also increased health promotion, again, through multiple role contact. So it could be that someone's not had a smear for, 4 or 5 years, well, 4 or 5 years, longer than that, you know what I mean? Quite a few years, and we could have been trying to contact this patient, need a decline code off them, and they could end up on social prescribing list, which is a discussion they could have if appropriate for what they're doing, and then we can kind of contact them in that way. So that's how we kind of work together, just to create a better outcome for the patient and create things more accessible for them. But yeah, so that's really at the end of all the comparisons and everything, and obviously the ways of working and stuff. But if there's any questions that anyone does have, please feel free to ask them, either for me, for Gracie, or for Josh. Whatever you need to ask, feel free. Nikki?
Just waiting for my camera to come on. Here we go. I'm just going to move you back onto my little screen so you don't get side view.
Okay.
You're dreading me coming on, aren't you, Darcie?
Yes.
So we've known each other for a long time, and we've known that I'm a care coordinator, that our roles are very, very different. I'm sure you'd agree.
Mm-hmm.
So I work with a caseload of patients. I don't work with cohorts of data, shall we say. I have, very similar to social prescribing, health and wellbeing, a cohort of patients. Currently have, I think it's 48 on my caseload. So I'll do home visits, follow-ups, welfare visits. I refer to services a lot each day and chase them up, which takes a lot of time, mainly through adult social care. A lot of my patients are dementia patients, so I work very closely with Alzheimer's and all the dementia, all the other dementia services and community groups as well. So I do actually work very, very different to probably most care coordinators, but I feel that my role is more in keeping with the workforce development than a lot of the other care coordinators are. So Darcie, you know when you put up this slide with the like a condensed thing from the workforce development, you know, on the care coordinator bit.
This one.
And I don't. It might not. No, there was another one. It mentioned. I can't remember if on the care coordinator bit it said that for supervision. There's one where it stated supervision for social prescribing. I think it did for health and wellbeing.
Okay, yeah.
Yeah, I get supervision because obviously it's non-clinical, but I work a lot with patients, complex patients. So
yes,
I do get that supervision support. Trying to think what else there was. I wrote a few things down. So yeah, I've mentioned about referring to services. You'd also mentioned something about no difference in level of referrals.
Yeah, so it tends to be that people who are, you know, like care coordinators, we do tend to refer onto certain services, kind of like we can refer on to Alzheimer's, we can refer on to CGL and stuff like that. But for people that need more support, like, you know, with normally housing finances, that sort of things that are more community based for them as a person, as opposed where it's not like a healthcare need in a way. So that obviously houses, finances, stuff like that, it's not necessarily primary care related to the health. So that's where it would go over to social prescribing, because they can support with a community base within those issues.
You see, our PCN have got a fantastic personalised care team, and we work very well and very closely together. So if I had a patient that was referred to me via task, being out to visit them, doing a home visit, and I've assessed the needs, the home needs, any safeguarding issues, etc. If there was another element of, I'm quite lonely, or I need help with my housing or something, then I would then just refer that on to the services that I know that can help with them.
Okay.
Instead of passing everything over to my lovely colleague Emma, who is on here. Because I mean, she gets enough referrals through anyway. So when it's something that I know I can quite easily do, it's just a phone call or completing a referral pro forma, then I'll do that and I'll chase it up a couple of weeks later. Yeah,
I think that's kind of like when I said earlier about obviously the mandatory training, where people do different training because they kind of like do a combination of the roles. I think that's where you fall into place. Like you're obviously still doing a care coordinator's job, but you kind of touch on social prescribing with some of the stuff that you do as well. So I mean, this is just me personally from obviously going through the workforce development programs, but I think because you do a lot of home visits and the way that you do work throughout your job role, I just think that you pick up more because you're kind of like more involved with the people, particularly when you're obviously doing your home visits. You get to know them, you can see where they're struggling with certain areas and stuff like that. So I think that's where you end up kind of doing that. Whereas in our PCN, and I know a lot of care coordinators, kind of we do assess the patient, but then we have avenues where anything to do with housing, it goes to social prescribing, so they can then have that conversation with the person, they can contact them, they can get to know them, they can do kind of that aspect of it. But you're already there.
We will actually do joint visits. I'll do joint visits with prescriber, joint with health and wellbeing, and also our cancer care coordinator as well will do, if we think it's going to involve more than one of us, we will do joint home visits. And then just one more thing, and this is something that really frustrates me, when people say that care coordinator role is an admin role. We were told right from the very beginning, during the training that you have to have, the mandatory training, it is not an administrative role. And that mine isn't. Apart from everyone does admin, doctors and nurses do admin, but it's not, you know, I don't work with, I work with data because I'm always checking my own data, but I don't have a cohort of data patients that I have to work through. Other than I will work with the care homes doing the personalised care support plans, so I'll run a report to see whose reviews are due. That's the only thing. Yeah, sorry. I've bombarded it now. I'm going to be quiet. You've heard it all.
Right. You're fine. I know what you're like now. Yeah, no, it's I think it's with care coordination, because obviously we've got the peer support network, and a lot of people do a lot of different jobs. I mean, when you go on the care coordinator mandatory training, there's so many different people on that are doing so many different things. They're still all care coordinators, but obviously they do completely different cohorts, completely different ways of working. I mean, we have which you're obviously a part of, the local care coordination catch-ups that we have, and everyone on there does different stuff. But I think the amount of admin as opposed to clinical completely depends on what the individual focuses their day-to-day on and how much they actually kind of get involved. So obviously people that have got, like I said, long-term condition, say if they're a respiratory care coordinator, they're going to have thousands of patients, especially in a big PCM. So their job probably would be more of an admin-based role, not necessarily fully admin-based, but because it's going to be difficult, obviously, to know all those patients. But when they're sending mass invites for, you know, reviews and stuff like that, and are working through that way throughout the year, then they would be more admin-based. But I think it's completely specific to the job role that we do, because there's that much that we can get involved with. I think it's dependent on, obviously, whatever the needs are of the cohort that you have. Whereas obviously you do dementia, so you're going to be a lot more involved with things. But yeah, I think it is just one of those things that's dependent on what your job's based around. Yeah, but if you want me to help you look into anything, just let me know and we can obviously have a look together.
Will do.
Yeah, could be interesting. But yeah, is there any more questions? Because I can't actually see people's hands up on here.
There was one in the chat, but I think Joshua's very kindly answered it already. So Sean had a question regarding how we find out whether we have a health and wellbeing coach within our PCN. So Joshua's kindly mentioned that the referrals on System 1 and health and wellbeing coaches are currently in Sherwood, Rosewood, Mansfield North and Nottingham West at the moment. So
yes, I was going to say, because I know in Bassetlaw, where I'm actually from, we don't have them.
Yes.
Yeah, so I've been in post for, it's 5 years this year, and we've never had a health and wellbeing coach. But we've never had one. We've got plenty of social prescribers. They all work through Bassetlaw Community Voluntary Service, so BCVS. And we do tend to have a couple that work for BCVS but are integrated into primary care to deal with, obviously, primary care's cohorts that they have. But we've never had health and wellbeing. That tends to just fall under social prescribing, but they would refer for that support. So like Josh was saying, we have great services through like BPL, which is Barnsley Premier Pleasure, for the gym stuff and that. So they kind of do that, but it is something that we don't have. It's interesting that how much they actually do and how beneficial of a role it is. Yeah.
Really interesting, thank you. And Jean Kirkby, I think you've got a question. Please do unmute and speak up. Hello.
Hello,
hi Jean. Hello, you okay?
Yeah, babe, see you. Listen, I'm really scary. I'll put my camera on, but it's really scary because I'm having a work from home day. I'm classed as a health and wellbeing coach.
Oh.
Yeah.
Are you?
That's what it says on my contract.
Oh, interesting. I didn't know that.
Yeah.
Right, okay. Because you base around cancer care, don't you?
I'm cancer support coordinator, but
Yeah.
my contract says health and wellbeing coach. Yeah. Pick bones out of that one.
That's interesting. I think that's. I mean, do you feel that your role fits being around a health and wellbeing coach, or more of a care
It fits
coordinator?
everything.
Fits everything. You're
I
like
think
a
it fits
combined role.
I
then,
am
aren't
all
you?
three. Yeah, absolutely.
Yeah.
I mean, when I first signed up, I did the health and wellbeing coach training.
Yeah. Okay. Have you done the care coordinator one as well?
No, I was told I didn't need to. But very, very, to be fair, health and wellbeing is very similar from the background I've come from.
Yes.
Pretty much exactly the same stuff. But yeah. So there you go. That might be a way to get one.
Yeah, that is. It's interesting. It's because you're in Retford PCN, though. I think you'd only be able to take them. But it's interesting knowing that. Yeah, that's something we could obviously discuss throughout Bassett Law to look at how it works.
Chat with that one later.
Yeah, thank you for that.
Okay.
Thank you.
See you in a bit. Bye.
Yeah.
Thanks, Jean. And there's also a little bit of chat in the information in the chat about F12 and use of ARDNs as well. My understanding, correct me if I'm wrong, everyone, is that they're not sort of mutually exclusive. You can be using both F12 and ARDNs at the same time, because I certainly did that in my own practice. They tend to link in better with System 1 in my experience. So it might well be EMIS practices that perhaps haven't linked in quite so nicely with F12 and System and ARDNs, but they're generally pathways for accessing guidelines, but also referral pathways as well. Personally, I love F12. I don't know what I would do without it in my workplace, but ARDNs I personally find a bit clunky, but yeah, as long as you've got some way of accessing the information, that's all that matters, I guess.
Yeah, we went from ARDNs to F12 and we've used it for quite a while now, and I find it a lot easier to navigate. Yeah,
I would agree with you, absolutely. But I mean, I can see the benefit of ARDNs as well, but I certainly don't think ARDNs replaces F12 in my view. Interesting chat there. Any final questions, everyone? Or it doesn't have to be a question, it could be a discussion point. Jean, please go ahead. Apologise.
All right. Yeah, I'd love some training on ARDNs at F12 at some point if we could do that.
That's certainly something we can work towards. Thank you for saying that. I would agree. You're not the only one who's mentioned that, and I sort of feel that in a way these templates are thrown our way and we're expected to just pick it up as we go along sometimes without having formal training as to how to make the most of it and how to use it smoothly. So yeah, let me see what I can do. I can work alongside the team and see whether we can arrange something. Lovely. If there's no final questions, thank you so much to Darcie, Joshua and Gracie. It's been a wonderful session. Any final questions or thoughts before we wrap up? No, if not, thank you everyone for coming. As Darcie mentioned, there will be a handout which Darcie will share with the team, and you'll usually receive that from the Alliance email address. There will be a survey shared with you all as well, so please do complete that.